Hello everybody, this is James, and today we're going to memorize the clinical features of hypercalcemia using a simple medical mnemonic, calciums. First, let's take an overlook. Alright, let's get started. So the aim of this video is to use the word calciums as a medical mnemonic to explain the clinical features of hypercalcemia. We will start with the letter C, central nervous system impairment. So what I have here is excessive calciums. The excessive calciums helps glutamate, which in fact is the primary excitatory neurotransmitter in the central nervous system, which I have depicted in green, to overstimulate the NMDA receptors. That stimulation causes more calciums to seep into the cells. In fact, that is not a good thing because excessive calcium influx leads to increased mitochondrial permeability, mitochondrial rupture, and dysfunction of the cell. So, excessive calcium that builds up in the neuronal cell leads to something called excitotoxicity. And this excitotoxicity, which is overstimulation of the NMDA receptors, leads to changes in the regulation of neurotransmitters such as dopamine, serotonin, norepinephrine, which play roles in the basis of emotions. So, in general, a patient with hypercalcemia may develop symptoms such as the psychic overtones, personality changes, memory impairment, depression, lethargy, confusion, or coma may all be a hallmark of the disorder. Abdominal symptoms, smooth muscle atony of the intestines, may cause nausea, heartburn, constipation, or abdominal discomfort. There has in fact been a link between peptic ulcer disease and high calciums. However, it is still not clear if the calcium receptor activation increases gastrin levels or increases basal gastric acid secretion. Excessive calciums in the cytosol supports the conversion of trypsinogen into trypsin that can cause acinosal injury. On top of that, calciums themselves may precipitate in the pancreatic duct, obstruct flow, and initiate inflammation of the pancreas, leading to acute pancreatitis. Considering calcium levels in the evaluation of vague abdominal symptoms, in my opinion, is a good practice. Lesions of the bone. In general, there may be signs of inflammation, cyst formation, or fibrotic changes. Osteitis fibrosa cystica is often used to represent these changes, and it usually presents as bone pain. Radiologic findings may include bone thinning, cyst formation, and salt and pepper pattern. What we mean by the salt and pepper pattern is a sort of a speckled appearance on the calvaria of the skull. It is multiple, very tiny, and very well defined opacities on the calvaria. Perhaps it is due to the excessive activation of osteoclast that leads to immense bone resorption from the bone trabecula. Cardiovascular impairment. Calcium has a positive inotropic as well as a vasoconstricting effect and may increase blood pressure. Blood pressure is a product of the cardiac output and the total peripheral resistance. Increasing vasoconstriction leads to an increase in the total peripheral resistance that increases the blood pressure. Positive inotropic effect in itself means increased contraction, and that can affect cardiac output and increase the blood pressure. Remember, cardiac output is also the heart rate multiplied by the stroke volume. Hypercalcemia inhibits myocardial depolarization and may result in a short QT interval that can predispose to arrhythmias. It's important to remember that excessive extracellular calcium restricts the movement of sodiums through the sodium voltage regulated channels. This alters the generation of cardiac action potentials and shortens the plateau phase with shortening of the QT interval. Now, if we will take a look at the action potentials in the ventricles, we do remember that it starts with phase 1, which is a rapid sodium influx. And at some point, there's going to be efflux, okay, of potassium. So it means potassium's out. Then that leads to the plateau phase, which is phase 2. And this is where there is influx of calciums. And there is the phase 3, which is repolarization. And phase 3 is more potassiums out. Now, a lot of students will ask the question that there seems to be calcium influx, so why doesn't that sort of widen the QT interval, but rather shortens the QT interval? So this is where we need to understand that there is an inhibition of the sodium influx by the calciums that are coming in, and that's the reason why this alters the generation of the cardiac action potentials. And so the plateau phase, which here kind of shortens because the sodiums are also inhibited. So we're going to have something like that, which is shortened, and that leads to a short QT interval. Nephrogenic diabetes insipidus. Hypercalcemia may lead to an autophagic degradation of aquaporin 2 water channel receptors, which usually is V2. So let me illustrate that here. So these water channel receptors helps in the transport of water across the membrane into the blood. Now, excessive calciums may also deposit in the tubular interstitial space, which causes nephrocalcinosis. Now, this will certainly affect the reabsorption of water and also increase the arginine vasopressin resistance. This is the receptor, and that will not be sensitive to ADH. So normally we have ADH, which is antidiuretic hormones. It comes and binds to these receptors, and so there is a transport of water across the membrane into the blood. Now, with hypercalcemia, there is a nephrogenic diabetes insipidus, so these receptors are not responding. Hence, the water is going to go into the urine and cause a dilute urine. We do have to remember that the sodiums here would rather increase in concentration, and so the osmolarity of the serum increases, but then there is a low sodium content of the urine, that is a dilute urine. So this is one of the signs and symptoms of hypercalcemia. It will lead to polyuria, and that can cause dehydration, and patients may complain of excessive thirst as well. Urinary stones. The long-term excessive sodium persistence may saturate urine and reduce the threshold for renal stone formation. The common stone is usually calcium oxalates. However, calciums may also bind with other substances such as phosphates. Complications such as renal colic, infections, hydronephrosis, sepsis, or renal failure may occur unless the primary cause of the nephrolithiasis is treated. Muscles. There may be skeletal muscle fatigue, weakness, muscle twitches due to the neuromuscular depolarization inhibition. Short QT on an electrocardiogram. The main electrocardiogram abnormality is the short QT interval. However, other ECG signs such as biphasic or flattening of the T waves, or an Osborn wave, which is a deflection between QRS and SD segment, may also be seen. An Osborn wave may look like this. So this is the Osborn wave, which is also termed J wave sometimes, Osborn wave. Thank you very much for joining me on Chalk Talk. My name is James, and I hope this was useful. See you in another video.